Measles is one of the most contagious human pathogens on Earth. In a completely immunologically naive population, a single outbreak will infect up to 95% of individuals by the time they reach 15 years of age. Through aggressive global vaccination efforts, the mortality rate has plummeted. Between 2000 and 2015, worldwide deaths dropped by 79%. Driven largely by achieving 85% coverage with the first dose of the measles-containing vaccine. This map displays global mortality data from 2015, set against the World Health Organization's elimination target zones. Despite significant progress, a stubborn gap remains. An estimated 134,200 deaths occurred that year. In displaced or isolated populations, the case fatality rate can reach 30%. Closing this final gap requires overcoming a specific clinical hurdle: the lethal convergence of active measles transmission and high rates of pediatric HIV infection. Eliminating the final reservoirs of the virus requires a precise calibration of vaccine timing against the specific immunological profiles of infants in high-risk regions. To manage this vulnerability, the World Health Organization issued this position paper in April 2017, establishing a definitive protocol for vaccinating high-risk populations. The strategy hinges on two distinct PICO questions. The first asks a matter of safety. Can a live attenuated measles-containing vaccine, or MCV, be safely administered to a child infected with HIV? Introducing a live, albeit weakened, virus into a patient with compromised T-cell function carries an inherent biological risk. The medical establishment historically hesitates to challenge an already suppressed immune system. The second question addresses immunogenicity. Even if the vaccine is safe, does the compromised immune system possess the capacity to mount a response and generate lasting protective antibodies? The data derived from these questions establishes the clinical logic required to vaccinate immunocompromised children and effectively close the transmission chains that sustain endemic outbreaks. To understand the protocol for high-risk patients, we first have to examine the baseline constraint: why we cannot successfully vaccinate against measles immediately at birth. This graph tracks two competing factors in a newborn's bloodstream. A mother passes neutralizing maternal antibodies to her child in utero. If introduced too early, these antibodies neutralize the vaccine virus before the infant's body can react. Simultaneously, during the first 6 months of life, the infant's independent immune system is too immature to reliably seroconvert and produce its own antibodies. We have to wait for an optimal intersection window. By 9 months, maternal antibodies have decayed enough, and the infant system has matured enough to achieve an 84% vaccine effectiveness rate. Waiting until 12 months pushes that effectiveness up to 92.5%. This dictates the standard World Health Organization schedule. Administer the first routine dose at 9 months in countries with high mortality risk, and at 12 months in countries near elimination. This timeline contains a fatal flaw. In areas where measles is actively circulating and pediatric HIV prevalence is high, leaving an infant entirely exposed for their first 9 months of life results in massive casualties. The clinical necessity of waiting for immunological readiness directly clashes with the immediate, localized epidemiological threat. To intervene earlier, we must look at the WHO GRADE evidence framework regarding HIV-infected infants. Looking at this summary of Grade Table 2A, the safety data is highly conclusive. Across 19 observational studies covering HIV-infected children, there is zero evidence of an increased risk of serious adverse events following immunization. The live attenuated vaccine does not harm HIV-infected children. However, safety does not guarantee efficacy. Table 2B evaluates the immunogenicity of the vaccine when administered at the standard 9-month mark. This forest plot visualizes the response data. HIV-infected children face a severe penalty in their initial antibody response, yielding a relative risk of 0.79 when compared to unexposed children. Even when they respond, they face accelerated antibody waning. Without antiretroviral treatment, protective immunity degrades rapidly. A Zambian study revealed the scale. Only 23% of HIV-infected children retained protective antibodies by the time they started therapy. While the vaccine is safe to administer, the standard protocol fails to provide lasting immunological memory for HIV-positive children. This demands a radical adjustment to the schedule. To close the vulnerability window for these infants, the WHO introduced a specific intervention, the MCV0 supplementary dose. Returning to our timeline, the WHO authorizes a supplementary dose to be given as early as 6 months in age. This is triggered during outbreaks, in refugee camps, or for any infant known to be HIV infected or exposed. Because seroconversion rates at 6 months are relatively low due to immune immaturity, there is a strict programmatic rule. MCV0 does not count toward the routine schedule. Regardless of whether a child receives this early supplementary dose, they must still receive the standard MCV1 and MCV2 doses at the national intervals. That protects the infant early, but it still leaves the problem of rapid antibody-to-patty and HIV-positive children as they age. The solution relies on HAART, highly active antiretroviral therapy. By suppressing HIV replication, HAART stabilizes the immune system. The WHO then mandates a strict revaccination strategy, an additional measles dose 6 to 12 months after initiating HAART. This creates a multi-layered immunological bridge. The MCV0 dose provides vital early protection, while post-HAART revaccination cements the child's immune memory. Securing immunity in vulnerable patients solves the clinical problem, but eradication requires scaling this math up to the population level. A single routine dose of the measles vaccine, even operating at its maximum 92.5% effectiveness, is mathematically insufficient to achieve the required herd immunity threshold. To halt transmission entirely, every national immunization program must hit an absolute standard, reaching 95% coverage or higher with both a first and second routine dose across every single district. This requires overhauling historical age restrictions. Policies that previously prohibited vaccinating children over the age of 1 year must be changed to intentionally capture older children and adolescents who missed their routine schedule. Isolated clinical successes with high-risk patients are biologically meaningless if the surrounding population lacks the dense 2-dose coverage required to stop the virus from circulating in the first place. To prevent the virus from finding a foothold, national committees actively monitor the accumulation of susceptible individuals to trigger supplemental immunization activities or campaigns. These committees map immunity gaps by integrating ongoing disease surveillance, demographic surveys, and historical vaccination coverage data. If these campaigns are halted before a nation locks in 90 to 95% routine coverage for 3 consecutive years, population immunity will immediately drop below the safety threshold, inviting a resurgence. The specific clinical needs of HIV-positive and high-risk cohorts rely entirely on the success of these broad mathematical campaigns to keep the ambient viral threat at 0. Eradicating measles demands precision timing across every layer of public health. We utilize the MCV0 supplementary dose to protect the vulnerable, mandate revaccination post-HAART to secure long-term memory, and aggressively deploy the second routine dose to engineer absolute global elimination.